Back to Medical Monday, we are talking hip and knee replacement with Dr. Roy Sandberg. Thank you for being here once again. We do have some calls tonight to get to. As always, we'll jump right to him. Kenneth is on the line. Hi, Kenneth.
Hi.
Hi, go ahead with your question.
When I was 12 years old, I had 3 pins put in my right hip because of the pelvis and the joint wasn't fully developed for that age. I had the pins taken out later on when I was 17. I'm now 58, and the hip is worn, and I can see a possible hip replacement later on. My question is, when I was 12 years old and they put the pins in, it stunted the growth of the hip, the leg length. My leg's about 1.5 inches shorter than the left one. Is it possible when they put the implant in there, can they lengthen this leg and make it the normal length as the other?
What an interesting question. That would be life-changing, I'm sure, in some aspects.
Yeah.
Can you do that?
Well, so Kenneth, I would preface this by saying, without actually seeing the x-rays, I think I'm following well enough to understand what the situation was. Without seeing the x-rays for sure and seeing exactly how much of a leg length discrepancy there is, I'm not sure. Typically, when we do a hip replacement, we do gain a little bit of length in that hip just by nature of kind of retensioning some of the muscles in order to keep the hip stable. That being said, to overcome an inch or so deficit would be pretty hard to do with just a standard hip replacement.
Okay. All right. Well, you answered my question. I appreciate it.
You're
welcome.
All right,
Kenneth, thank you for calling in. We also have Lee on the line. Good evening, Lee.
Oh, yes, I appreciate you taking my call.
Sure thing. What's your question?
Well, just to give you a quick overview, without taking too much time. I'm 64, I'm disabled, and I've got knee and hip problems for a long time, and also it goes down to my foot. But the question I had here is, I really don't know what to do. Now, I've had 1 x-ray on my knee, no MRIs, and I do have a lower back L5 or 6 from birth that's degenerate, and I'm trying to get information on what I should do. You know, I'm going to have to go to an orthopedic because it's gotten so bad now, so severe. I mean, chronic pain. I'm taking, pain medication just out of the guru. Anyway, it's getting so hard where I can't walk very well. I can't cook. I can't hardly do anything because all my focus is trying to minimize the pain.
Right.
And so I just wanted to hear what the doctor had to say and whatever.
Sure.
Also, I wanted to know if I do need a knee or hip replacement. Would he recommend both of them done at the same time?
You know what? That's a great question because I just asked it, so I'm going to say it's a great question, but we'll let Dr. Sandberg ask it.
So thanks for calling, Lee. So to answer the last question first, you shouldn't have a hip and a knee replacement done at the same time. When I hear someone that's saying that they're having pain in their back, in their hip, in their knee, all the way down to the foot, typically that's something that we think more of spine pathology. And I know you mentioned you had a disc, I think you said at L5, and that can also cause pain where it's difficult to walk, can sometimes cause numbness, tingling, chronic pain like you're talking about. When we talk about arthritis in the hip, sometimes you can have pains that radiate down to the knee, but it's very rare that you have any pain that moves past the knee down into the feet and toes. So to me, if Lee was in my office, the first thing on my mind that I'd want to do is see what his spine looked like, because that sounds a little more like what the pathology is. Now, that being said, people can certainly have spine disease and hip arthritis and knee arthritis, and then it becomes up to us as a physician to try to delineate, well, which of those is the most symptomatic.
Right. And
there's different things we can do. We can do things called diagnostic injections, where we select a certain area, either the knee, the hip, or the spine, inject a little numbing medicine in that area, and then have you walk around, and we say, how much better is your pain? Is it 0% better? Is it 50% better? 100% better? If we inject your hip and 100% of your leg pain goes away, well, then that's probably your pain generator, and you would do well with the hip replacement. If we inject your hip or your knee and you say, that didn't do anything for my pain, then a joint replacement wouldn't help you. So the first step would be to try to just get evaluated by an orthopedic surgeon, look at all of these issues, and really try to delineate what's your pain generator.
And going in for that first appointment, he should expect an X-ray, MRI. What would you do?
Yeah, typically if somebody like Lee came to me, I would start with X-raying the hip. Depending on how bad the knee was, we'd probably get X-rays of the knee as well. Depending on what those looked like, we may then get an X-ray of his lumbar spine. If you want to talk about MRIs, the only MRI that would be of utility, I think, in his case, depending on what his X-rays looked like, would be an MRI of his spine. So typically, once somebody has arthritis in their hip or their knee, you don't really need an MRI to give you any more information. It's like zooming up on worn out tread on your tires. You don't gain any additional insight. You know it's worn out. You know, so figuring out every little tear and nook and cranny that's worn out on the tire tread doesn't help you solve the puzzle anymore. You know you have to replace the tread on the tires. So MRIs for arthritic hips and knees that already show arthritis on X-ray, probably not a whole lot of use for that.
Well, it's kind of good news. It saves a little money, too, in the long run.
It does. It does.
I mean, not having to go for that MRI. Let me ask you this also. So many doctors seem so specialized these days that sometimes if you don't know exactly what your problem is, it's hard to know where to go. So you said that you're a hip and a knee guy. He maybe has a spine problem, but maybe a hip and a knee problem. Where does he start?
The short answer is that you can really start with either of them.
Because you're an orthopedic surgeon.
We're both orthopedic surgeons. You know, typically spine surgeons can either go an orthopedic surgery route or a neurosurgery route, but we're very used to having crossover patients, meaning in my hip clinic, it's not uncommon for me to see somebody that has lumbar spine disease. And so if I find it, we're tuned into the differences in the symptoms. We then refer them on to the spine surgeon. And likewise, if a spine surgeon has somebody coming in for low back pain or buttock pain that their primary care doctor thought was sciatica, then if they do an X-ray and move their leg around and say, you know, this seems more like hip arthritis, well, then they'll send them over to me.
Gotcha.
So the good news is that in some ways Lee can't go wrong. He can go to either place and they'll probably be able to help him get where he needs.
Good. That is some good news. And I was asking you during the break, if somebody has either, you know, one side hip replaced or one knee replaced, does it mean down the road that the other knee will go bad? Is there any correlation whatsoever?
There's not 100% correlation. We do tend to see there is some evidence coming out that shows some maybe familial clustering of arthritis. There were some studies done in Utah that showed there was maybe a genetic component to osteoarthritis, and we certainly see that if somebody has a hip or a knee replacement a few years later, you end up replacing the other knee or the other hip, but it's not always. Sometimes people do just have one that goes bad. Maybe they had a trauma to it at some point and that's what started the whole process, and then they end up just having one joint replacement and that's all they ever need. So I would say it's highly variable.
Okay, good info. Let's go to Ida. She's on the line, waiting ever so patiently. Hi, Miss Ida.
Hi, how are you?
Good. Go ahead with your question.
I want to know, okay, I have the arthritis, it's the degenerate arthritis in my knee, and I had a MRI done, and he said that I wasn't bone to bone yet, but I have so much pain in it and stuff. So if I have a knee replacement, would that help with the arthritis, regardless whether I'm not bone to bone or anything?
So this is a good question that we see a lot. And again, it's hard to say for sure without having more time to ask her more questions, examine her, and exactly see what her imaging is. But one thing we do know is that patients' pain does not always correlate with how severe their X-rays are or their other imaging studies. Meaning, I've seen patients that have terrible looking X-rays and they function rather well. And likewise, I see patients that have some arthritis, maybe not quote unquote bone to bone, but they're debilitated. And so what we try to do is treat the patient and not treat the X-ray. And so it would be some additional questions I would like to ask that patient, see what other treatments she's tried, but certainly we've done joint replacements and knee replacements in patients that maybe were not quite bone to bone, but were severely debilitated, and they have an arthritic process that would benefit from a joint replacement.
Hopefully that answers your question, Ida.
It did.
Okay.
Thank you.
Thank you for calling in.
Thank you.
Let's talk about when a patient comes in and they're maybe not ready to make the jump to I need a replacement right now. Where do you start when someone is in pain?
So when someone is in pain, I think one of the biggest things that we can do as physicians and especially as joint replacement surgeons is to try to empower the patient and say, look, this is an elective surgery. So the concept of somebody needing a joint replacement, I would say, is a very slim margin of people that actually need a joint replacement. So it is a quality of life decision that you have to decide, how much is my pain interfering with the activities that I want to do? And I use the example a lot of a ladder. So if you need to change a light bulb in your house and you can change that light bulb effectively from the second rung of the ladder, well, there's no reason to climb to the 6th rung to change the same light bulb. You just introduce more risk into the scenario. But if you can't change the light bulb from the 2nd rung, then maybe you do need to go up some more rungs on that ladder. And treatment of arthritis, whether it's in the hip, the knee, the elbow, is pretty much follows those same principles of you start and say, okay, well, what activities can you modify? If somebody comes to me and they say, my knee only hurts when I play golf, and I hate playing golf, then guess what? Your treatment of your knee arthritis is you quit playing golf. You know, so there are lots of different things you can do. That's called activity modification. So how can you modify your environment? What things are you okay giving up with? If that same person comes to me and says, my knee only hurts when I'm playing golf, but I have to play golf, otherwise I'm going to be depressed and miserable, well, then we need to find a way to help that person play golf. There are medications that can be tried. There's home exercises that can be done, and the right types of exercise will rebuild the strength in the knee or the hip, and that can be quite beneficial in resolving some of the pain that people have. Injections are another step. Certain types of injections work better than others. So there really is a decent number of non-operative things that can be tried, and it may not be the magic cure-all that cures your knee pain for the rest of your life, but it may save you 4 or 5 years. A case in point is my mother-in-law. She had some early arthritis in her knee, kept seeing doctors, couldn't get any relief. We put her on a home strengthening program to just do some daily exercises of her knee every day and use a stationary bike. And after 5 years of doing that, she still has never really sought out any additional treatment of her knee pain. It's helped tremendously. So sometimes just the simple things can actually have a big impact.
Do you call and check up on her? Are you doing your exercises?
I just saw her. She came and visited us last week, and I said, how's your knee doing, Misty? And she said, you know, I still don't have any pain in it anymore. I keep doing my exercises. So that's her treatment for her arthritis.
Very good. Okay. When we come back from commercial break, we'll talk about when people do need to make that jump to hip replacement or knee replacement, what to expect in surgery and after. So stay with us, and if you have questions, go ahead and give us a call. We're coming right back.